it's wonderful to introduce Santiago Fosser. How do you say your last name?
Fosser.
Fosser. So Santiago, we hired recently. We're very happy to have hired him because he's working with us as a clinician informatician, and he is part of a group of highly qualified. Hey, everybody heard that. Who are tasked. We're hiring them through an FRQS grant, and they are tasked with really enhancing the organization and access and usability of our clinical data at the MUHC for research purposes and quality purposes. And we have a full house with now all my favorite people. But if you're online, you're my second favorite people. So take it away.
Okay, thank you very much for the presentation and the invitation. I present again myself. My name is, you can say to me, Santiago. So I'm going to be presenting data access for research, basically at the data warehouse at the MUHC. So let's start. So the following presentation is going to describe and summarize the data warehouse access process for research. And we're going to see, first, we're going to name the policies and procedure at the Research Institute, the introduction to the data warehouse, from raw data to research, the structure of the data warehouse, the content summary, some terminology that they are used at the data warehouse, and also the current data access process description. And then I'm going to speak about the next step that we are going to have based on this project. So basically, the data policy and procedure, the most important one is a 2019 policy, speaking about governance des activités informaticiennes. This maybe is not actualized, but if you want, is the most biggest policy at the Research Institute, at the MUHC, speaking about how to access data. And we have a lot of procedures and policies speaking about the data at the MUHC, but any of those ones speak specifically about how to access the data, being a researcher, how to access the data, like the whole description of the procedure. This is the policies at the Research Institute MUHC, data management plan, clinical data management. But again, any of those procedures and policies describe how to access the data. What should be doing the user to access the data. So the idea is to create a new data governance framework, to develop a data governance framework to adapt existing processes to facilitate data access and identify requirements for a consent registry. We're not going to speak about this, but the idea is this is going to be the umbrella, how to access the data at the MUHC. So basically, the data warehouse is an episodic patient-centered database. This is very important because all the data that is inside of the data warehouse and also to the hospital is always linked to the patient. So any data is going to be linked to a patient ID and identifier of the patient. And also, if it's a data created during an episode, it's going to be linked to an episode. And combines transactional system hospital data across MUHC sites to facilitate access to data sets for quality, performance, and research. And it's available for 2019 for research purposes. Before, it was accessed only for quality and performance. So this is maybe, it's not up to date, it's 2019 data. So we have 3 years ago, but just to give you an impression of what is the data inside. So the majority of the data is lab, emergency, imaging, is taking the half of all the data, and the rest is split between all the sources. In total, for 4.6 million patients, 5.5 million episodes, and a lot of databases, tables, columns, rows, and billions of actual variables and facts.
4 million individual.
Yes. Yes.
Not 4 million. There's no patient that is.
It's historical data too.
Yeah, but it's not one patient that appears twice because it's different episodes.
No. It's patient, individual patient. It's intended to be. This is the data that I have since a few years ago. Maybe it's historical data, so it's not current patient at the hospital, but maybe they're past. And
Like 5 million. No, it'd be 540,000. That's Quebec City. It's 8.6 million in the province. I just looked this up.
sorry, in the province, to my knowledge, is around more than 7 million. Maybe I don't want to go. So, yes, sir.
But I guess this is historical.
This is historical too. Yeah. Sorry, I don't know. I don't know since what year we have data, but it's historical data too. Yes.
Because he was asking the patients, who have, let's say, 4.6 million there, but you have 5.5 million episodes, so then some patients will have multiple.
Yeah,
episodes,
yeah.
But they don't appear as like
Duplicate.
duplicate.
Yeah.
patients. Different.
Yeah. One patient. I don't know what is the average episode per patient, but it's more than one for sure. Yeah.
Figure.
Yeah.
It's just under about 5 million. You actually have 5 distinct Quebecers in your unique Quebecers.
No, sorry. It's if you want, we can discuss that later. But it's not only Quebecers. It's anyone that came here to the hospital and get a registry and pass to have some service. So it could be a Quebecer, it could be someone from another province, another country. Yeah, sorry, I don't have the answer right, so I cannot answer.
Are good ones, because this is exactly what I expected.
Yeah, perfect. Yeah.
There are really 4.6 million patients, and I think we should know.
Yeah. We should make a query to the database and extract all the patients and count them. It's not very hard, but I didn't do it recently.
That Margarita says, I suspect the patient count is not for unique. It's more likely to be a count of MRNs.
But then that's a whole other thing, because MRNs, there's one for.
Hospital side, yeah.
That's what it is. It's one per hospital.
Okay, if you want, I can verify that. I can check this and give you a correct answer right now. How many patients? Okay.
But this raises an important issue then, that we need to know, that Lara needs to, maybe you can repeat what I'm saying, Santiago, because we really shouldn't care what their MRNs are, and we should be able to merge those and be sure that we have.
Yeah, they're all mergeable if you want by the patient ID, patient unique ID.
Anyway,
But currently they have separate IDs for each MRN.
see the MRN.
Sorry, wait. If you want we're gonna speak about the identifiers right now. So it's gonna come. Basically, this is how the no. We're gonna get back. This is all the process from the data source. So basically, we have 18 data sources as the hospital, and we have a ETL process that basically is an extraction, transformation, and load process. So basically, we extract the raw data and we try to organize in a better way, and we collect it in a real database that is an enterprise database, and we have an anonymized database. So basically, that is the data warehouse, accumulation of data already processed by the real source. And then to deliver, we have for performance, quality improvement, and research. And basically, it's a SQL query how to extract the data. Okay. The structure is a patient-centered database link within an episode of care at the MUHC. MUHC sites that are all of these sites. Data is extracted from over 18 sources. There are transactional systems with less than 24 hours delay between the creation of the data to incorporation in the data warehouse. Established process for research data access that is already working. A full team of analysts with research expertise, publishing, grant writing, ethic application, and methods to create those data sets. This is Lara is is an analyst. In the past, they have the experience to working with research. That's the point.
That's a very important point, because I think a lot of us really are interested in working with this, but to know who's who.
Okay, yeah.
Just picture
research when name, some of them presented it before, I think.
Yeah.
Just for us to understand.
Yeah. If you want, at the end, I have the list of all the names, and yeah, and this presentation is gonna be available. So if you want, that's the whole idea. So basically, this is the structure of the database of the data warehouse. In the middle, is everything is episode based. So we have a episode ID and all the information inside. So for example, an episode could be admission or another day surgery or another episode. And the MRN and site demographic. So speaking about the terminology of the data warehouse. Yes. Yes.
Like the admission, first admission, or is it the admission? Go to the hospital, that will be considered
An episode, as a definition, is a service that the MUHC is providing that have a start and an end. That's the definition of an episode. Have a start and end, and it's everything that occurs in the middle. If you have an hospitalization, you arrive to the hospital. Normally, you arrive by the emergency, and they create an episode. After the emergency, they create an episode, hospital episode, and you have a start date and an end date. You came back 2 weeks later, you have another hospital episode, and you have a readmission. Actually, it's a hospital readmission, but there are two separate episodes. Okay? Yes.
That's why probably 5 million episodes, which I'm sure is the correct number, could not be for 4 million patients. Because most of our patients are elderly and you rarely see a patient who's only been once seen somewhere and nothing else happened in the rest of their life.
It's a good point, yeah.
It's like more like 5, 10.
It's a good point.
Better biased because you have a lot of people coming in for deliveries, this, I don't know if pediatrics are involved in this.
Yes.
Go to the emergency, like that. So there could be actually, population wise, a lot of people only for one episode,
Yes.
Even among kids, it's.
All right.
Okay, if you want, this is a kind of a research question, how many episodes per patient we have. This is a thing that we can make queries and try to extract those data and have the answer. I didn't do it, but
Hello.
yes, sorry, Lara.
Camille already looked it up. It is actually 4.8 million unique patients.
4.8.
Without merging, so
That's merging.
That's merging the MRNs.
4.8 million unique.
Yeah.
More even than what we do.
no, yeah.
So maybe that number is a few years ago, and now we reach 2 million more. So I continue. So this is the terminology used. So basically, medical terminology vocabulary are terms and their synonyms to record patient findings, circumstance, events, or intervention with sufficient details to support clinical care, decision support, research, and quality. Basically, we have these groups and domains that they're using terminologies. For example, diagnosis, or I would like to say maybe observation, but not all the observation. For example, symptoms, they are not diagnosis, so it's an observation. And the data warehouse terminology that we're using is ACD9, and it was changed to ACD10 a few years ago. So basically, all of them is ACD10. So as a standard terminology, ACD10 is a standard. And also, for example, SNOMED CT is another standard terminology for diagnosis. For the procedure, for example, appendectomy or another surgery, we use the CCI code. This is the Canadian classification for health intervention. That is the standard that we're using, and also is a common standard here in Canada. For the drugs, we use this classification, AHFS, and DINS classification. This one is the American Hospital Formulary Service. That is also a standard. I put another one. There is a EREX norm. There's another standard to classify the drugs. For lab concept, to my knowledge, we use a local terminology to classify the labs. For example, if you want to make a blood test, all the description and all the codes inside the local terminology. A standard terminology, for example, is LOINC, that to my knowledge, we are not using this terminology. And for the image, and more specifically for the PACS, not for the image to order an image, is how to process inside the image. We use the DICOM terminology, but the PACS is not inside of the we don't extract the PACS information to put it in the data warehouse. So we are not, we don't have the DICOM system in the data warehouse. Yes, at the hospital, but not at the data warehouse. Okay.
You have the report, but not the images.
Yeah, correctly. So the report we have as a free text, the report, but not the current the image, not the images.
I ask Santiago?
Yes.
So, as a clinical informatician, why was it important to present this to us?
Okay. Yes. So basically, if you want to create a cohort and you want to study a specific cohort, you can Google and download the dictionary, and basically you can create your population based on this terminology. For example, if you need to study the drugs, say whatever drug, it doesn't matter, you go to the drugs and you look the classification of DINs, and you have a list of 20 DINs that you want to study. So when you make the request to the data warehouse, you send, I want these 10 codes, for example. Another one for diagnosis is the same. The good thing with terminology is like a tree. So you have one term, and inside of that term, you have more specific and more granular detail. And you can group them, and you can create data sets of terminological data sets and make a request. I want all this information that's going to say, I don't know, these 10 ACD-10 codes. And I want all the patients that have diagnosis with that. And with that, you can create a cohort and you can make research. Okay. This is just to say the terminology that we have at the data warehouse, and this is an example of a standard terminology.
Are we making it standard, or?
To my knowledge, yes. A few months ago, I spoke with the people at the lab, and they're trying to map the terms to LOINC. To my knowledge, we don't have it available. Yeah.
So to just continue Sophie's question, basically, if I send you a line.
Yes.
And then
I'm not gonna know. I'm not gonna be able to make the query to extract the LOINC codes because it's not registered as LOINC. Understand? But if you send other ICD codes or DINs, we can make a query trying to grab those variables or those data. Okay, so we have a data dictionary. This is available at the Research Institute. So it's intended to be a clear, detailed description of variables, definition, and attributes of data elements being used or captured at the data warehouse. Basically, we have a list of sources. We have the domain, source system, data type, update frequency, hospital, and year of data capture. We have a hospital and emergency data flow. This is going to describe the patient arrived, and we have a diagram and where the data is extracted. That's very good to understand how the data flow is doing. We have a list of variables organized by source system, but the 18 source systems, and this is the source system that we have available. And we have around 165 variables per each of the tables. So it's very hard to read, to understand. And also is a version 2019, and it's also in French. That's the only thing available to understand the data inside of the data warehouse now. Yes, sorry.
I didn't need to ask a question slightly just from before. Something like X-rays, like
Yes.
imaging, or pathology, and
Yeah.
having only the reports. Is
Yes.
there any plan to ultimately include this rich data, the actual, because imaging is all electronic. All X-rays are kept in a software at MUHC, so it's already there. Is there any plan to connect it?
Yeah, I don't have any answer to give you about that right now. I'm not aware, so I don't know.
But it would be good to know.
Yeah, it would be very nice to do it. And yeah, yeah. And now we're gonna
Very, very data, very memory intensive.
So let's start. So my idea now is to try to show you a summary description. It's intended to be a summary, but it's not a summary. It's very extended. But we're going to speak about the variables itself, so you can understand what is the data inside. The idea of this presentation is not to learn all the variables, maybe to know that, okay, maybe I want to look in the future some variables, and it's gonna be there, so you can check it after. So
take that mess of this variables that are very operational and really hard for us as researchers to wrap our minds around, but to kind of reorder them and regroup them in ways that make sense for us, right? Because otherwise.
So basically, I have two first objectives. One is to understand what is the data inside, and the second one is to understand what is the process that the researchers should follow to access the data. Okay, that's the main two objectives that I have at the beginning of my job. So basically, the patient identifier demographic. So we have a unique patient ID. This unique patient ID is a as I say, unique. So if the patient go to another hospital and have several MRN, it's going to have one unique patient ID. First name, last name, father's name, father last name, mother last name, date of birth, sex, RAMQ number, MRN, address, postal code, phone number, civil state, death, birth country, language spoken, and residency. No. No, to my knowledge, is happening inside. It's not a ministry database that is providing the data.
But you could not record that as data, because if the patient is good, they're not gonna come and start an
No, but the question is good, because maybe it's a database from the ministry that is collecting from all the province, and we have that data, but I think it's not the case.
It's not the case.
It's not the case. Lara is mentioned. It's not the case.
Yeah, sorry. United States, they can have all death dates.
Yeah. Yeah. Yes. I saw, if you want the variables, is not very clear because maybe it's a mix variables, but yes, we have that as a possible variable. So about this first variables is intended to be patient identifier demographic, episode information. For example, we have data warehouse identifiers. We have a global episode ID, dossier ID, patient unique ID, episode type. So we have emergency, inpatient, day surgery, episode start date, episode end date, episode duration, episode patient age, episode site, episode patient postal code. Sorry, I'm not going to read all the variables, but for the ADT, for example, we have variables for the admission and information for the discharge and for the transfer. So it's.
Outpatient visits are not.
Sorry again?
The outpatient visits, are they counted as episodes?
No, they're not episodes. No.
So we don't have any dates.
Yeah, we have dates, but it's not classified as an episode. Yeah, if you want, it's another table. The episode table is going to describe the episode, that is this one, and includes several variables. But the the outpatient visit, it is, if you want, it's another table.
I mean, that's the largest number in our.
Yeah. I don't know the answer. I can guess that it's very difficult to put the end of the visit. The episode is very clear when it starts and when it ends, but the visit is very hard to put where it ends. So at the beginning we have when he arrived, but at the end, so it's not.
That's the same.
No, because the day surgery have a discharge.
So the problem is, and the challenge is that those hospitalization episodes are really like carefully curated by the medical records people. So the outpatient visits are like outpatient visits anywhere where they're not, I don't think, curated that way. So, you know, you can trust a lot of the information, the diagnostics and so on from the.
Yeah, but not in clinic.
But not in clinic, so, you know.
So I'm not going to read all the variables, but we have information about this is ADT. Basically, it's manage the admission, discharge, transfer information, and we have variables for the admission, discharge, and also the transfer details. For example, the origin and destination, the unit admitted to, the program, so program service, and other information related to the transfer and the admission. So we have another source that is archives or Medeco. This is only for inpatient and day surgery. So we have intervention, diagnosis, DRG, service, and consultation. For example, an intervention, principal intervention, secondary. We have the code and the description, the date, physician service, diagnosis. We have principal, secondary, pre-existing diagnosis, complications, and all classified by ACD-10 in this, if you want, source of the diagnosis. The DRG, that basically they're going to take a patient and they're going to create a severity scale and mortality scale. Yes.
Dr. Bernowski has asked about outpatient visits.
Hmm?
Just repeat that outpatient visits are not.
Yeah, the episodes are in hospital or day surgery. We have also a pre-admin episode, but all the outside visits that the patient is doing to a clinic, they are not considered an episode. We have those information, but it's not considered an episode. DRG, my understanding is a group that they classify some comorbidities and some variables for a patient, and they make a classification in severity and mortality, and they put it on a scale. I think it's 1 to 5 about severity. So I don't know the group, but I know that it's in the table, so we have those information.
Tell Lara to
But I think based diagnosis related groups, and they do account for severity, but it's not like I never knew that Canada ever uses DRGs.
I saw the information. We have each patient at the demographic, if you want, is classified based on the severity.
And there's a number.
Yeah.
Wow.
Ask Lara.
Sorry, I can't hear the people's questions very well. I can only hear Santiago.
Okay, Lara, if you want, they're asking who make the DRG severity and mortality scale for the patient at the MUHC.
I believe it's the archivists. And
Okay, so it's the same group.
I remember, I think this is the one that Serge was saying that it's redone. I think they send it to the ministry, and then the ministry might do corrections, and then once a year they get that updated.
Correct.
So I think that would be important for Lara or you to look into, because this could be a useful variable. And the way you group things is really nice. If we could find out more details about that.
Okay, yes. In this presentation, I intended to do that. Like, if you want a summary, I don't have examples of each variable. That's like if you want another step for details. Yeah.
This is it's a form of shadow billing by the government, these DRGs, because everywhere, any hospital, when you compare hospitals, you need DRGs because you cannot say we had 5,000 patients, you guys had 10,000 patients, you had twice as many. Some patients are lighter than others.
So
But that's where severity. Yes, so in the States, they get reimbursed that way. Canada doesn't reimburse, but the ministry still wants to compare apples with apples between two hospitals to know who gets a bigger budget and so forth. That's where I think it's shadow, to me, it's a shadow way of. We don't.
Okay. Yes.
Services, physicians.
Service, physician, specialty date, duration of a service, consultation, domain, physician date. If you want, if I understand correctly, a consultation it could be, yeah, in hospital, if a group of physicians ask a consultation for another group and they make a consultation. Domain. Yeah, I think it's specialty. I don't remember specifically, but yes, I think consultation, for example, orthopedics.
Lara also says, regarding why there are so many patients compared to episodes, patients include all the patients in the source database, Clinibase, while episodes only started in 2008.
The ratio.
I don't understand what I'm reading, but here we go.
Okay.
How old are the patients? For historical data,
Since when we start to record patients?
We started including how
Patients.
old patients can be in.
Okay.
The question
Yeah, Lara, what is the first date of birth that we have recorded for the patient?
Well, no, because
Um,
100-year-old that was.
Yeah, okay, you're right. You're right. I think Lara understand the question. We got yeah, when we start recording the patients. Yeah.
That I don't know,
Okay.
maybe 2001.
2001. Okay, so now I want to speak about the drugs, about medication information. So basically, this is the cycle of the medication. We make a prescription, transcription validation. Some system we don't have this step. Basically, when someone make a prescription, let's say it's a paper, and someone is going to read it at the pharmacy, and they transcribe and then make a validation that the data is correct. Sometimes we have electronic prescription, and this step is not there. So we have the dispensation at the pharmacy, the administration, let's say it's an inpatient administration. So the nurse at the unit is going to provide the drug at the patient, and we have a monitoring of all the system. That's basically is the prescription cycle. So we have the information of the drug prescription, prescription episode type, inpatient, day surgery, emergency, ambulatory, pre-admin, prescription ID, start date, end date, frequency, dose, drug, generic name, instruction, road, patient height and centimeters, patient weight in kilograms, prescriber name, prescriber license number, prescription status, site, and the different site that we have the prescription. And each drug is classified with these two standards. There is a DIN classification and HHFS. Any question about this?
Just two different drug.
Same drug have different codes. One is more, the DIN is super specific, is more granular, and the other one is more broader. Yeah, is more group. But there are two standards. For the dispensation, we don't have information about the administration itself. So the nurse is not going to put in the system something that we're going to collect at the data warehouse, but we have drug information about the dispensation at the pharmacy. So we have, it's a transaction. So it's a transaction ID, prescription ID that's going to link to the prescription. Unit send, dose send, unit of care, patient location, dispensation date, transaction instruction. For example, 5 milligrams, and we have the prescription. And I think this is a free text. But all the rest is all variables that are structured.
You're not expecting those to be too different.
Between these two?
Yeah.
No. But sometimes maybe in the dispensation, they can split it in a different way, but the same drug. So this is about drug information. About the infection control. So we have highly concerning identified microorganisms. Basically, this is a table of patients that they are identified that they have or had a patient that is classified as highly concerning microorganism. For example, COVID-19 or MRSA. We have the start date and the end date. We also have the infection details, type of nosocomial infection, comorbidity, risk factors, symptoms, invasive procedures, surgeries, before the infection-related medical device, antibiogram, antibiotics given to the patient, status indicator in hospital, surgery, secondary infections. We have hospital information about those patients, hospital admission date, and there's some relationship between hospital information and infection. For example, the presumed origin of the acquisition of the infection, the care unit type of acquisition, the care unit acquisition, the infection from, the infection form by nurse. So the nurse is going to complete a form that at the end, we're going to collect those data. And if basically is the form is completed or not, valid, non-valid, or rejected. And if it's an infection that occur at the beginning of the MUHC, we're going to have the episode ID of the acquisition. So we have specific department that they have their own system to manage the information. So basically it's the emergency and the intensive care unit. They have, if you want, their own database that they collect data, and we have it as a source. So the emergency, we have triage information, vital signs. So I'm not going to read all the variables, but we have a lot of variables that are collected at the emergency. We have the diagnosis, and we have the lab orders requested as emergency. And the emergency, if you want, is not cataloged as an episode ID, the same that in hospital is. It is a episode. It's an emergency episode ID. If you want, it's not the same kind of episode. We call episode ID when it's an in hospital or day surgery, for example. And an emergency, if at the end is going to be admitted, then we create an episode ID. So intensive care unit, we have ACU episode ID, episode creation date, episode ID, that's going to link to the hospital ID or the hospital episode ID, service, ACU team, attending. We have also the ACU readmission. So basically, if the patient is readmitted to the ACU, we classify as no, this is not a readmission, or yes, this is a readmission more than 48 hours or less than 48 hours since the ACU discharge. We have conditional admission if the patient is have an intubation or ventilation requirement. ACU death, it was dead at ACU. Date, cause of death, and if have an autopsy. Complication, ACU procedures. If they have a procedure at the operation room. We classify also, this is something made at the ACU. We classify the Apache. I don't know how to pronounce this in English. Apache, okay. So basically, it's to measure the morbidity of the patient. Basically, this is for pancreatitis, but then is where used. So we classify as if you want, it's a score to measure the mortality, the morbidity, and the SOFA, that is also a score. We have the diagnosis, admission, principal, secondary, and ACU discharge diagnosis. All those diagnoses.
These episodes are not counted separately from.
If you want, we have an ACU episode ID and an episode ID that is the hospitalization. So, for example, maybe we have one number of episode ID. The patient go to the hospital and have several ACU in the same hospitalization. Is going to share the same episode ID and a few ICU episode ID. Okay. Yeah.
For a patient admission, and then you click on it, then you got several lines. Every time the patient moves to the ICU, out of the ICU, that's one. Obviously, that becomes one episode because they use Oasis for this data warehouse. Data storage.
So about the surgery, we have surgery request information, and the procedure itself. So the surgery request information, we have episode type of the request. So maybe it was a request made during the hospitalization, or it was another episode that the patient had at the moment of the request. The site, the operation room block location, medical priority, service, MD reference, expected surgery date, planned anesthesia type, intervention specialty, and order demand status. And we have information of the procedure itself, main intervention details, comments, secondary intervention details, procedure time, anesthesia type, post-operative diagnosis, and the sector and the operation room, the procedure specialty, pre-op and post-operative primary and secondary diagnosis, like all the information related to the surgery. I don't know if you have any question about this kind of information.
Even though the data are similar on Oasis, we don't use Oasis because Oasis is proprietary and they would charge us. So the data are actually coming from the same sources into the warehouse.
Right. Yeah.
Into
No, I get
Oasis,
it.
but
Yeah.
it's not the same.
Totally makes sense. Yeah.
So we have lab and images information. So lab, we have about all labs, requesting site, requesting origin. For example, if it's an inpatient or refer in, sampling date, result verification status. That's for all the information in lab. And then we have three main sources. We have general lab, microbiology, and pathology. For general, we have the result value, unit, reference, interval, specimen type, specimen source, specimen type, test, code, and the description. So basically it's a number with the description. And we also have the abbreviation of that code. And this is the standard that we're not using LOINC. That maybe would be nice to switch to LOINC. Microbiology, result, sample road, organisms, susceptibility to antibiotics, specimen type, specimen type, specimen source, test code, and the description in the microbiology. And the pathology, we have the reception date and the report text. We don't have image for any pathology, just the report that is written as a free text.
So why is this collaborative images?
Imaging, medical imaging, it was coming just now. So we have medical imaging, that is if you want another services, that we have the request information and the exam details. So the request information, episode ID, exam code, that we use a ministerial code to classify the image, and the description, that's for the request. And the request creation date, the request origin, we have the emergency. If the patient is a private office and it was ordered an image, we have those information too, the site and the unit, the exam plan date, the priority, patient age and weight, and at the moment of the request. So if the patient changed that, and in a few years, we have different variables of that. So we have also the exam details, episode ID, anatomy site, date start exam, and all the variables about the exam details. And basically this is radiology, cardiology, and nuclear medicine that is doing the images. And the result, we have a free text. So we have another source that is blood bank. So basically the patient have a blood test, blood group, antibodies, patient verification ST analysis result, that if I'm correct, this is a kind of verification just before doing the transfusion. They verify that is matching correctly. We have information about the product itself that is going to be transferred to the patient. It's going to be make a transfusion. So we have the lot number, product code and name, product type, stable or non-stable, product blood group, and product phenotype. About the transfusion itself, we have an episode ID, transfusion details, transfusion date, start and end, because maybe it takes, I don't know, 1, 2, 3 hours to make the transfusion. So we have the start and the end, allergy, transfusion reaction, if it happened, and we have the date and the reaction type. So basically that's the summary of all the data of the data warehouse. The idea is not to learn all the variables now because there's a lot of variables available at the data warehouse, but maybe if you're working something in relationship with this kind of data, you can take the PowerPoint, or the idea is to upload a summary with this information to the portal so you can read it and check the information. So before requesting the data, a principal investigator must have a privilege, an appointment at the Research Institute, the MUHC. The data warehouse must ensure that that the data is there. So we're not going to ask for data that maybe is not going to be there. So the idea is if the researcher can check the data before or have a consultation with the data warehouse team to understand better the data if needed. And need ethical approval for all the requests and consent and DPS if it's a nominal data. The data warehouse analysts assist researchers to understand, explore, and access the data. Basically, we can do a request using AT-Rescue consultation request, or write an email to if you have any question or something about the specific data, we can answer that. And this is the current process to access the data. So basically, we split in 2 steps. The step number 3 is the actual requesting of the data. The step number 1, if you have any question, you can make a consultation and IT rescue. And the step number 2 is to obtain the research ethical board approval for your research project. And the number is required when trying to request the data at the data warehouse.
That now, data are start a request kind of, but then they won't discharge it, they won't execute it until the ethics is there.
Yeah, so before, if you want the step 3, is actually requesting the data. It's the same process, is going to the portal and making an AT rescue data set request. And the analyst is going to contact you, and basically the researcher how to fill an intake form to describe what is the variables that they want. The specification, sorry, this is more about the research project itself, and the specification form is going to describe all the variables that is requesting.
Mara points out that you don't need approval in order to start a request for data.
It's very important, because that's what was creating the bottleneck. So the bottleneck was one of them, is that people were thinking they had to go to Naginum first, they got their ethics approval, and then the data they needed wasn't there. So
Yeah.
Cycle, so we said, no, we want them to go directly.
That's
Yeah.
what Bernaschi asks, what about lab results? I'm not quite sure what that was in relation to.
Lab results.
So this is all the lab results. We have all labs and general microbiology and pathology, and these are the variables inside of the tables. I don't know if Sarah have a more specific question. Okay. So basically, this is the analyst team is going to make a back and forward with the researchers, try to agree that the data is available at the data warehouse before doing the extraction. And a final request is sent to the data warehouse programmer, that is the person doing the query to the database. A final authorization to begin the research, if it's authorized by the Rev approval, so we can go on and move forward. And the programmer review the request and extract the data, and then it's going to give it using a Nextcloud. I think they have 2 ways to give the data. If it's anonymized and if it's not, it's more secure or less secure way. Yes.
For step 1 is basically that's whether the data is available or not. Right?
Yeah, so basically, if you are not sure that the data is available, we recommend to send an email or make an IT rescue to say, okay, I'm working in this, I need this information. So we can say, yes, we have it, we don't have it. Basically, it's that, and agreeing that the data warehouse is going to answer your question.
Then
Lara. You don't need the
Yeah, so you want to start the process rolling before you
Yeah.
start the approval process, because the approval process takes a while.
Yeah, so basically you can start the process without having nothing. Now you can do any question with the step 1. The step 3, you need the Rev approval to have the real data
That means you don't go through a whole.
to finish the 3. Yeah.
No, I mean, I usually would prefer outpatient data.
Okay, but we have outpatient data. This is not available. Yeah.
Well,
I remember at the core retreat, there was issues.
but the outpatient data does not have diagnostic.
If you want, it's not more details, but we have some information about. It depends your question that you have, your research question, and we have to validate that the data warehouse have the information that you need to answer your question. That's the point.
Just submit a request to the data warehouse for a consultation.
Yeah, I will need information of outpatient visit. I don't know your research question, but
Where does in your scheme of the data sets coming together, 18 sources and so forth, where does the outpatient data come from? You said there's no episodes, they're not marked as episodes. right?
yeah, they're not marked episode. But not all the data is marked up as an episode.
So do you know what we have for outpatients?
So, for example, if someone is making an image request and they are in a private office, we know that the request information is not going to be linked to an episode because have no known episode, but it was done in the private office. So we have a request origin classified as private office. So that information is an outpatient. That's an example. We have more information.
part of maybe what you help lead.
Yeah. Maybe we need another group saying outpatient data and describe the outpatient data. Yes.
Thought, and you'll have to see if it's possible, is if we can take the major clinics, like we have diabetes clinics, we have lupus clinics, we have heart failure clinics, and we know what clinics they are based on how they're booked in the, there's a booking system. So even though we don't have like a or even we don't have a diagnosis, we know that people have gone to those clinics. That's what we know, right? So if you've gone to an asthma clinic, I'm gonna put money on the table, someone thinks you have asthma, right? So we need to be able to do that. Because right now, we sort of say, well, we don't have diagnoses. But of course, we
Okay.
have diagnoses. They're hidden.
Maybe for next time I can make a group outpatient information and list what we have, because maybe as is now is maybe split in other groups.
So the issue is that we do have very limited outpatient specific data, as in what clinic they visited and the date.
But the what clinic, Lara, shouldn't it be in our booking system? You have access to the hospital booking system. I've forgotten the name of it.
I'm not sure where that data comes from, but the point is right now it is not available for research.
No, but the point is that it should be, and that's part of this project. So the
Yeah.
idea would be to go to that booking system, find the labels of the clinics, because, you know, there are specific clinics that we have, and at minimum, know which clinics patients came from, because that would help us identify the patients of interest for sure.
Yeah, once the outpatient data is ready for research, that is what we will have, but that is all we will have. And then when a doctor sends a request for a service like lab or medical imaging from their office, that is actually, there's a third type of episode, which is like a pre-admit, and that would go under there, and we would have that information as well.
But that's not
outpatient
to us, right? From a research standpoint, we don't really care that someone randomly gave it. What we need to know is groupings. So what I'm saying is we have to find out, we meaning you guys, have to find out, you know, what that booking software is and where those data go. Because I know it's a central booking system and it would be available, you know, to us. So in that central booking system, when my secretary books in the diabetes clinic at the MUHC, that's a diabetes clinic and it's diabetes that's getting booked there. So by inference, we could then say these people likely have diabetes, and it's the same for other clinics. So now we need to open up from what we have to what we have data for and could bring in and start making the moves to do that. Because otherwise we're going to just keep saying, we don't have, and then we're not going to use our clinical data meaningfully. So it's not a critique, it's just now let's be proactive and figure that out.
Okay.
So what I wanted to say is that the request that a doctor would make, we do have that, because that's not outpatient data, that's pre-admit data.
Yeah, but that's not useful for us.
Okay.
We need the outpatient clinic disease classification. And then we can take those other data and group them accordingly.
Yeah. And apparently the two sources of data that we do have, the Info Center performance team has access to, is MediVisit and eRendezvous. But
So
those
there
are
you go. So MediVisit, that is where the gold is. And I think that's not been used properly. So the MediVisit would have, you know, you might have to go back to the original departments there, but there would be certain clinics and certain physicians that do certain clinics. So there could be some backwards mapping to help figure out what broad disease category people belong to. And that's already a step forward.
Yeah.
What I'm trying to understand from what
Yeah.
Lara is saying, sorry, and I hope to step out,
But once we have that, and I totally agree with you, that's doable. You can probably map it back to the cardiovascular pod or the chest institute or the cancer, or, you could probably do a lot of that. But once you have that, my question is, what actual data is available?
So you wouldn't have
That's
the
what I'm trying
text, but at least you would know, okay, now the labs I'm getting for these people could be relevant. Now the hospitalizations for these people, like, you don't have you're right, you don't have the text notes or whatever, I don't think. But you have, otherwise, like if I want to do, an examination of A1C values, I could, but they don't belong to anybody. But if I have like that I know that they went to this clinic, and then I know this lab belonged to them, and this echo belonged to them, I might start to be able to construct some aspects of that.
Step one, I want all the diabetics.
Yeah.
All
like
patients with renal
start
failure.
with something, right?
Second step, how many of them have proteinuria?
Yeah.
diagnosed?
Like you could pull all the
Step
labs
two,
for people that you've seen, right, in congenital heart disease clinic, like at least you'd have somewhere to start, and then whatever data are available in the system, they could be mapped back, but otherwise you're just sort of have, because otherwise they'll tell you, go to the labs and find the A1C, but what does that mean to me? I don't know, were they people in our system, were they not, like
We do have that information already.
which information?
If we wanted to look up A1C, we can find out who the requesting physician was, and we know the patient ID.
Yeah, but that's on a physician by physician basis. So
Yeah.
the idea is exactly.
That's also useful. right?
Maybe, yeah.
Because,
Yeah.
this is what we've done in our database, is we've used all that information, like who's making that request, like, who's an endocrinologist.
Yeah.
That's all coded out.
Mm.
So,
Mhm.
so
Mhm.
we,
Yes.
so that every specialist has a code. So for example, in my congenital heart disease database, I don't take any ICD-9 that hasn't been made by a cardiovascular
go to that
specialist. And I reverse engineer from the surgical intervention.
So that's what I need. It's that kind of thing that we need to do. Yeah, you reverse engineer. Okay, that's interesting. Yeah.
So you look at the data, so let's say you have a unique identifier for a patient. Then you're gonna look at the confluence of data in multiple dimensions.
Yeah.
To construct your bucket of information for that. Your grouping of variables for that individual.
That's exactly it. So that's what we have to start doing. Yeah, I think that.
So we've done that actually quite successfully with just data. The inpatient, the outpatient, the primary diagnosis, the secondary diagnosis, the surgical interventions, the diagnosing physician, and the number of times a diagnosis is made.
The consistency of.
And we're just about to publish that because we developed an AI algorithm that actually does it for you.
Oh, okay.
So
Yeah.
once you have those pieces, you can actually automate it. And we went back and we tested our automation against our manual reviews.
Do you know that then you've identified a cohort of the condition with a
Yeah,
condition
because it's
exception?
very easy.
Yeah.
As long as you have a starting point and then you have like a little algorithm.
Yeah.
Then you end up with,
And you can validate it because it was made by someone
Yes.
who was able to make that diagnosis. So this is we're actually going, can they hear what I'm saying? Can they hear?
Vaguely.
Probably yes.
Vaguely. So we're actually going to interview the in-person interviews for the software engineer. There's one this week and another. Anyway, so that's coming to work alongside.
Yeah, the idea is to try to maybe improve the database and take in consideration different sources as an outpatient and booking system to try to improve.
a large data source that you have. And then you clean from there. You don't start with the narrows, you start with the largest, then you start to exclude.
It's 5 o'clock, we should
Yeah.
go.
Oh,
Yes, it's if you want to do this, This is the last. This is the last one. So basically, next steps about documentation is to create a data summary document. Basically, it's very similar to the information that I show in these slides, but create a document and make it available in the portal, and create a data dictionary 2.0 that we're also working on. Update, simplify the data request specification and data access process document. Try to write all this process to access the data. Process improvement, we're currently redesigning the data access process and evaluating Jira service management to request, manage, receive the status notification, and communicate with the data warehouse team. So this is not being used AT Rescue, it's another software, Jira, to try to create a ticket, create a request, and we can track those updates in the request.
No, we're a bit over time, but are you actually able, because of the data set is anonymized or at least de-identified, does that though enable you to say, if I've gone to the ward, for example, like to the CCU, and I've consented 3 or 4 patients to a trial, I want to track all of the outcomes through the data warehouse, for example.
Okay.
Let's say lab values, etc.
Yes.
Is that possible here? Because I've got now 5 or 6 patients, but I don't think so because it goes through a de-identification process.
No. If you provide the identifiers, yes. If you have a protocol approved to study the patients and you make a request, I need information of these 5 MRNs, yes. The data inside of the data warehouse is not anonymized.
Because in your workflow, there was a phase of de-identification.
Yes. If you want, we have 2 different databases, the one de-identify and one with identifiers. And the approval are different to access one or the other one.
But you have consent here. So
But if you have the consent of the patient to access the data, that you need the to actually access identify information, you need the consent of the patient. If you have it and the protocol is approved and
Consent or DPS.
I just want to say, that's a little bit last century. Okay?
Mhm.
Because what you should be able to do is create a systematic algorithm for de-identifying.
yeah, I agree.
So that, because this is what I do with GramQ, this is how I get my data updates. They have the real MRIs, right? But they have a specific code to give me a scrambled identifier. Every patient in the MUHC should have a specific scrambled identifier. So that if I want to say, I want to look at every patient who came to heart failure clinic in the cardiovascular pod, right? And I send you a list from Oasis of everybody who was booked in the heart failure clinic. Then you de-identify the MRNs and map them back to a skeletal structure that allows you to find them in your database. And then you don't have to have, you don't have to have identified data, but you're the one that scrambles and unscrambles. You know the coding.
I think that's what they're doing.
No, if you want the data warehouse have their own patient unique identifier for the data warehouse, and it's going to identify uniquely each patient at the data warehouse. But we also have a lot of identifier of the patient. I say if the hospital have to identify the patient. So it's the same. It's the same security at the hospital. So there's no an issue having that information identified at the hospital.
But I mean, it seems like that link between the identified and the de-identified piece has to be very sturdy. Because otherwise it's impossible to get permission from every single patient for every single lab test that you're gonna look at.
But it's 2 different, like, I think it's 2 different things. What Abhinav is asking for is like, he's consented, there's certain things he wants. But what you're talking about is the other thing we do, which is to get a whole group of people over time
and they do have like unique identifier and, you know, they'll send you the data.
Identify, de-identify.
They're doing what the ISP does.
You have time, I don't know if Iowa, because my lab is on the line, but we've actually worked with you guys and gotten data. And
Okay.
But you should talk to Santiago, he's gonna.
Yeah. And sorry, the last part, if you want to finish the presentation, to process improvement and also the human resource capability to improve teams' privilege, such as giving data warehouse access to analysts so they can understand better the data and maybe create themselves the extraction to make it faster. And the other one is to incorporate a software engineer, data scientist, and data governance expert for documentation.
So data governance started. And
Wait, go back to the. Want to know about the data augmentation. This was discussed a year ago at the core retreat. That another core retreat, the core retreat.
what are we talking about? Sorry?
Yeah, synthetic data or
Synthetic
yeah.
data,
Oh,
yes. The plan with Shiva or Shiva, whatever, that place, is that happening or not?
Yes, if you can, we can speak about that. Yes.
No, but in fact, that's why I spoke to you now, because I was waiting for that. Okay, so it's happening.
Yes. If you want, we can. If you want, we can speak that in a few minutes. I can give you an update if you want.
Santiago Marquez,
Yeah, this is my email. So if you want any question, I'm gonna try to make available the presentation. And
No, and I think you can put this should go on the portal with all the data warehouse stuff. This presentation should go there. Too,
okay.
because it organizes the data better. And our interview with the software engineer, you should come. Because I think we have to start asking them up front to do this kind of stuff. Because I'm just, you know, the team that's there has been doing your work and that's great, but now we have to move forward and bring in other stuff to make it useful to us, because otherwise it's not. You know,
it would be maybe interesting if there are people in the audience who have actually dealt with the data warehouse and gotten data to share their experience.
Absolutely, yeah, and that's what we were asking, what you met with a couple of.
Yeah, if you want, I made with a few researchers virtual interviews to have their experience trying to access the data. Yeah.
Can you
Okay.
Well, can you see if Iowa View is on the call? Just because it was a real struggle for us. It took us, I don't know.
Well, at the beginning, the process was difficult.
I don't
And
even
there was a
see,
lot.
like, not everyone has their full names.
Now.
But Marianne, it was a difficult process because they were just getting started and they were swamped with people that wanted data. They didn't know how to do it and all that stuff. But at that